Hey, I'm Dr. Wilson. I'm a PhD molecular biologist, and welcome to another COVID debunking video. So not too long ago, some of my friends and I on a Twitter space got into a discussion with a Twitter user who has over 500,000 followers and is an anti-vaxxer. This guy's name is Viva Fry, and he wasn't too bright. It'll become clear in this video that his intentions were not to have an honest discussion. However, during the discussion, he did bring up a lot of things that I think average people might be concerned about with COVID vaccines, and so it's worth making a video going over those things and what the data actually say. And to chime in with this video, I have one of the friends who was on that discussion, a clinician in Canada, Dr. Jonathan Laxton.
Hi, I'm Dr. Laxton, and I am a general internist at a very large hospital in Canada where I have seen a lot of hospitalized COVID patients. I also helped design a virtual outpatient COVID program and see a lot of long COVID patients in my clinic.
So in this video, we're both going to discuss what he said, why it's wrong with science and data, and we're also going to point out the hypocrisy and dishonest tactics of people like him. Viva Fry also made a recap video about the space, so we're going to be including clips from that, as well as the space itself, and addressing all of those points. So with that said, let's get started.
The Twitter space started off productive as far as I was concerned. We got to some consensus that Fauci either lied or at the very least was wrong. Albert Bourla misstated or at the very least loosely described the 100% efficacy in the South Africa study. The media got things wrong. Experts got things wrong. But as would be seen in the context of this space, all of these experts, PhDs, well, they could be trusted, their data was accurate, et cetera, et cetera.
This is what Viva Fry came into the space saying, and it was just completely dishonest. His whole point was that because the media or certain public health experts that he saw on the news or read headlines about got things wrong in those news clips or in those headlines, then therefore we can't trust any of science, any papers, any publications, any data. Yeah, that's seriously his point. But he has to make this poisoning the well fallacy because, as you'll see, he doesn't know anything. He doesn't know any science. He doesn't know any data. He doesn't know any facts. He just knows what he has seen in headlines and news clips. The truth is that, yeah, some public health talking heads that the news media was focusing on got things wrong. And that's understandable in a pandemic where information is very fast-paced, it's dynamic, and things are actually changing. But if you actually paid attention to the scientific literature the whole time instead of news clips and headlines, then you wouldn't be as confused as Viva Fry is. For example, scientists knew early on that COVID vaccines were probably not going to maintain a 95% protection against infection. That's because we understand that vaccines are meant for protecting against severe disease, not infection and not necessarily transmission. This is because when you get vaccinated or infected, you get a big response from your immune system, and that response includes creating a lot of antibodies. Those antibodies are going to remain in high levels in your blood, but over time, as the infection or the immune insult is gone, then your cells are not going to keep producing that same level of antibodies. So those levels will wane. When those levels of antibodies wane, you can become infected again. But upon the next infection, thanks to the previous immune response, you're going to have an immune memory that's going to kick in and protect you against severe outcomes from that infection. This is how every vaccine works. Yes, even polio, measles, smallpox, all of these vaccines worked on this same principle. That's why we see that polio virus is still around in the environment. We just don't see many cases of it because most people are immunized and can produce an immune memory response before it gets to your central nervous system and paralyzes you. The difference with SARS-CoV-2 and COVID is that the incubation period for SARS-CoV-2, especially Omicron variants, are on the order of like 3 days, whereas the incubation period on a virus like, say, measles is on the order of 10 to 12 days. So therefore, with measles, you have a lot more time for your immune memory to kick in and prevent you getting that characteristic rash that is measles, and thus you never know if you're infected with measles. But with SARS-CoV-2, which has a very short incubation period, you feel those symptoms, you test yourself, and you know you have it. Scientists have been explaining these things and communicating these things since 2021. Good example of this I'll point you to is This Week in Virology. So if you ever want good information on infectious diseases and vaccines, even in future pandemics, I highly suggest them as a source.
But here are our vocabulary for today. So we have 3 words I want people to learn about: infection, disease, and severe disease. So I'm going to throw in, we got a little bit of information about infection. I think this is important because this is going to tie in with transmission. So the endpoint was not whether or not people got infected. The secondary endpoint was not whether or not people got infected. It was whether or not they get disease and whether or not it was severe disease. So what's infection? Can you get infection without getting disease? And this is, I think, an important point. Our TWIV listeners probably know this, but it's good to sort of go through. So you've got the elevator response ready to go. Sometimes a pathogen, a virus in this case, can actually infect us, use the same word, that can actually go and start replicating, but we don't know it. We have no symptoms, we have no fever, we have no headache. We are infected asymptomatically. The concern there is that if that happens, if the vaccine does not prevent that, you could have people getting infected, walking around, feeling fine. They've got the virus replicating in their nasopharynx. They might wipe their nose, they might talk, they might potentially transmit it, and they feel fine. They're coming to work.
Daniel, what was the percentage in the prevention of asymptomatic infection? You didn't give us that. You gave us the disease.
I know. I believe it was 67%. Is that correct? Am I remembering?
Yeah. So it's not great, right? So a lot of people are still going to not be protected from infection.
But Viva Frei didn't understand any of this. He just watches the news and reads the headlines and says because they got some things wrong, then therefore he doesn't trust them. But as you'll see later, he doesn't apply this same standard to the people that he trusts, who systematically got things wrong, but he thinks that's okay.
They were wrong in saying that the jab would prevent transmission or protect you. It's as clear as black and white. I have that highlight.
Like I just explained, preventing transmission is not the primary goal of vaccination. With a disease like smallpox, you could do something like ring vaccination, where as soon as there was an outbreak, you could quickly go in and vaccinate all of the contact. You could quickly go in and vaccinate all of the contacts around the people who are involved in that outbreak. And that would stop transmission. And it did. That's how we eradicated smallpox. Because all of the contacts had an immediate boost of antibodies that were going to neutralize the virus and prevent it from spreading, then you stopped the spread. But with SARS-CoV-2, which is everywhere and has a short incubation period, that's much harder. However, the data are very, very clear that SARS-CoV-2 vaccination does reduce transmission. This has to do with that immune memory I talked about earlier. Because the immune system is already trained to recognize SARS-CoV-2, when you get infected and you're already vaccinated, then your immune memory is going to kick in and create a much faster response that is going to much more quickly clear the virus from your body relative to someone who has no prior immunity. This much faster clearance results in a shorter window of infectiousness and thus a lower likelihood of you to spread it to someone else. This has been measured both on a cellular level and on a population level. Will this effect stop transmission of SARS-CoV-2 and stop spread of COVID? No, absolutely not. But it does reduce the risk. And choosing a path where more risk is involved doesn't make any sense. And a lawyer denying the data that he doesn't even have the expertise or the patience to begin to understand also doesn't make any sense.
That they were wrong in denying that the jab could produce certain adverse events like myocarditis or interfere with women's menstrual cycles. We agreed on that.
We absolutely did not agree on that, because nobody ever said that these vaccines could not cause myocarditis. And the thing about women's menstrual cycles is something he's very confused about. But here's Dr. Jonathan Laxton talking about myocarditis and COVID vaccines during pregnancy.
So Viva Frei focused a lot of the conversation on myocarditis. Just to clarify for everyone, myocarditis is inflammation of the heart muscle and is different from a myocardial infarction, which is the doctor word for heart attack. And that's where you plug the blood flow in the arteries to the heart and part of the heart tissue dies. Myocardial infarction is one of the leading causes of death worldwide. Myocarditis is not very common. So myocarditis is a rare serious adverse event that has been associated with the mRNA COVID vaccines, and the highest risk group is males 16 to 24 years old, and the highest risk is after the second dose, especially of the Moderna vaccine. So vaccine skeptics like Viva Frei tend to present myocarditis as almost one of the worst things that can happen to you. Listening to some of them, you get the impression they think it's almost worse than dying from a deadly virus. And it's fundamental that they misunderstand the concept of risk-benefit analysis. Nowhere was this more obvious than when Viva Frei asked his big gotcha question, what rate of an adverse event is too high?
What rate of adverse event is too high for you? The real truther, please just answer me that simple question.
This is the wrong question because it depends on the risk of bad things happening without the intervention. For example, let's say you're a healthy person and I say, hey, I want to give you this drug just to prevent you from getting cancer in case you do in the future. The side effects from this drug include losing your hair, getting sores in your mouth, severe nausea and vomiting, burning in your feet from nerve damage. It can damage your heart, and it can wipe out your immune system for several weeks, resulting in you being at high risk of infection. Oh, you'll also get really bad diarrhea. You would very likely tell me to take a hike, and I would completely agree with your risk-benefit assessment. Now let's change the scenario. Let's say you have a cancer, and this cancer has limited your life expectancy by 6 months unless I give you that chemo drug, which could cure your cancer and help you to live longer. In that case, the risk-benefit analysis will change quite significantly, and you would be more accepting of that side effect profile to help have a chance of curing the cancer and living a normal life again. So you can see you can't just say what rate of myocarditis is too high. It depends on the risk-benefit analysis. What does the infection do to you, and how well does the vaccine reduce the risks from that infection? That's what needs to be considered when determining whether to continue with a vaccine that has a known adverse event. And you guys actually all saw this in action in 2021. The viral vector vaccines, including the Johnson & Johnson AstraZeneca, had a rare clotting disorder associated with them that actually resulted in a significant number of deaths, 6 in Canada, 9 in the United States, and several in Europe as well. Therefore, the risk-benefit of those vaccines was not as favorable as the mRNA vaccines. Plus, they didn't work quite as well at preventing severe disease as the mRNA vaccines. Therefore, those vaccines were removed, and the mRNA and Novavax vaccines are now used preferentially because they're safer. So to perform this risk-benefit analysis, the first thing we must do is determine what the actual rate of the adverse event is. Now, Viva Free likes to present a single study from the Public Health Agency of Ontario that was repeated by Dr. Kieran Moore, who was the Public Health Officer of Ontario at the time. It found a 1 in 5,000 rate in 16 to 24-year-olds after the second dose. However, picking a single study with a rate that you like isn't very honest. For example, there are a couple studies that show no increased risk of myocarditis after mRNA vaccines. If I just presented those 2 studies and said, look, there is no myocarditis associated with mRNA vaccines, that is also not very honest. So a type of study known as a meta-analysis, where they take multiple studies and put them together to find a combined rate of all the different studies that are out there, is a better way to determine the overall rate of myocarditis. And these have been done. The overall rate has found to be anywhere from about 1 in 30,000 to 1 in 44,000 doses of vaccine. And in considering risk-benefit, we also look to see if there's a high-risk group that we can identify and modify things to help that group. And in this case, all the studies have shown that males 16 to 24 after the second dose of vaccine are at the highest risk for myocarditis. We also like to try to identify if there's a specific vaccine or thing we're doing with the vaccine that increases the risk. In this case, we found Moderna, which is a higher dose, 100 micrograms versus Pfizer's 40 micrograms, was associated with a much higher rate of myocarditis. In studies, it was up to 1 in 2,000 to 1 in 5,000 in the highest risk group of young males after the second dose. The Moderna vaccine was also the only one associated with a higher rate of myocarditis and COVID infection in males under 40 after the second dose, which you can see in this figure here. For the Pfizer vaccine, the rate is lower. It's anywhere from 1 in 6,000 to 1 in 18,000 in young males after the second dose, and you can see that in the studies here. And once we discover and characterize a risk like this, often we modify our recommendations to reduce the risk as much as possible. And both Canada and many European countries put out warnings in the fall-winter of 2021 that males under 40 should preferentially receive the Pfizer over the Moderna vaccine due to the higher rate of myocarditis associated with the Moderna vaccine. And this was backed up by the literature I just showed you. So the other thing we looked at is whether the timing of the second dose impacted the rate of myocarditis. Is getting the second dose earlier or later associated with a higher rate? And it was found delaying the second dose actually reduces the risk of myocarditis. If it was given 30 days after, Moderna had a rate of 1 in 12,000, and 56 days after, it was 1 in 62,000. For Pfizer at 30 days, it was 1 in 19,000, and if it was delayed to 56 days, it was 1 in 100,000. This was a strategy actually used by the United Kingdom and Canada, not for myocarditis, but it may have reduced the risk of myocarditis in young people in those countries. So the final piece, and much more pertinent to today's situation, is whether or not the booster doses are associated with as high a rate of myocarditis. Pretty much nobody is getting the 1 month apart doses anymore, and the booster doses are primarily being used, which are delayed anywhere from 3 to 6 months after infection or a previous dose. And it was found that the rate is much lower in the highest risk group, 60 to 24-year-old males. The rate was anywhere from 1 in 25,000 to 1 in 90,000. The other thing to note too is the Moderna dose for a lot of the boosters is lower, which also would have helped lower the risk of myocarditis. So now that we've examined the actual rate of myocarditis associated with the vaccine and ways we could reduce that risk, it's important to ask, what is the risk if you aren't vaccinated or if you get a COVID infection? And the risk is actually quite significant. This study here found a rate around 1 in 5,000 people that survived hospitalization, so not people with mild myocarditis in the community. However, it did exclude people that died. So this was only in survivors, and if the myocarditis from the COVID killed you, you would not be counted in this study. So we've already established that 16 to 24-year-olds are at the highest risk of vaccine-related myocarditis, so it's important to look at the risk from COVID in that age group and make sure that the benefit and risk calculation is in favor of the vaccine. And this preprint here in 12 to 19-year-olds found a rate of myocarditis associated with SARS-CoV-2 infection of 1 in 2,000, which is significantly higher even than the Moderna vaccine. And to show I'm not cherry-picking a single study, here is another one from the CDC showing an excess rate of myocarditis of 1 in 1,200 in 16 to 24-year-old males. We say excess because there is a background rate of myocarditis, which they accounted for in this study. So the NCAA also did a study in 2020 before the vaccines were available in their athletes and monitored people after infection to see if they developed myocarditis. They looked for both asymptomatic and symptomatic myocarditis, and they were using cardiac MRI. Asymptomatic myocarditis was found at a rate as high as 1 in 60. However, they did not account for background rates of myocarditis. And most of the vaccine studies don't look for asymptomatic myocarditis, so that is not a good comparison. Of the symptomatic people, the rate in that study was 1 in 320. Now, it was a smaller study, so I'm more likely to believe the little bit of a higher rates of 1 in 1,200 to 1 in 2,000. Last thing we need to consider in our risk-benefit analysis is there a difference in severity between vaccine and COVID-associated myocarditis? Myocarditis is not a single disease. There are milder forms and there are very severe forms like giant cell myocarditis, which has a 50% mortality rate at 5 years without a transplant. So in this large cohort study from the Netherlands, it was found that vaccine-related myocarditis had a much lower risk of hospitalization or heart failure than either conventional myocarditis, which is mostly caused by viruses, as well as COVID-19 associated myocarditis, which was at a higher risk of these bad outcomes than conventional myocarditis. This study in the United States also followed people that had developed vaccine-related myocarditis, and 90 to 94% had complete normalization of the blood tests and other testing that showed myocarditis at 90 days. 13% still had some abnormalities on MRI that were consistent with myocarditis, and 68% were cleared to return to sport. So they did pretty well for patients with myocarditis. Often when we discuss myocarditis, the anti-vaxxers bring up died suddenly, often referring to athletes dropping dead on the field or passing out or other young people dying suddenly. It should be noted, though, that sudden cardiac death has been a leading cause of death in athletes since sport was invented. This other study was done in Veneto, Italy, which is a state in Italy, and found that there was no increase in the number of sudden cardiac deaths in people under the age of 40, and the proportion of causes of the cardiac deaths did not change. For example, myocarditis didn't suddenly become a very large chunk of the sudden cardiac deaths that they recorded. So this very large study from England looked at the risk of death in people 12 to 39 years old. And what they did was a self-controlled case series, meaning they looked at the death rate in people before they got vaccine doses and then up to 12 weeks following each vaccine dose. And they found no increased rate of either all-cause or cardiac death after receiving either dose of the mRNA vaccine, meaning that there was no increase in death associated with either dose. If myocarditis was causing lots of death, we would expect an increase in deaths after the second dose because that's when myocarditis is the most common. A very similar study was also performed in Italy, which found the same findings in 12 to 39-year-olds. There was no increased risk of death following either the first or second dose of the vaccine, which is not consistent with widespread deaths from vaccine-related myocarditis. Even when the anti-vaccine Surgeon General of Florida did a study properly, his sensitivity analysis based on dose found no increase of cardiac death following either the first or second dose of an mRNA vaccine. He, of course, deleted the sensitivity analysis so he could present the study as claiming there was an increased risk of cardiac death in young people. This was actually quite dishonest. And this final study, using a cardiac arrest database in Australia, found that in Victoria State, there was no association between the number of vaccine doses given and the risk of out-of-hospital cardiac arrest. So not only is the rate of myocarditis associated with COVID infection much higher than vaccines, it is also much more severe, and there has been no signal of increased deaths following vaccination in young people that are at the highest risk of vaccine-associated myocarditis. So then after all this, Viva moved on to talk about compounding risks, saying the 1 in 10,000 will occur after each shot and each infection, and the myocarditis rate will go through the roof, and eventually lots of young people will be afflicted with myocarditis. However, this is incorrect for multiple reasons. Studies like this Patron study have suggested that the risk of myocarditis from COVID infection is actually reduced by being vaccinated, even in males under 40. It's about 50% less develop myocarditis if they were vaccinated with COVID than if they were not. And as I already showed you, the risk of myocarditis with booster doses is much, much lower than it occurred with the original series, even in the highest risk age group. Therefore, there will not be compounding myocarditis cases from getting booster doses. Also, the young people are not really uptaking the boosters as much, and it's not available in some countries to them. So evidence already suggests that the vaccine reduces your risk of myocarditis from COVID. However, there is even further evidence that it reduces the risk of other cardiac complications that go along with infection. For example, this Korean study shows reductions in both ischemic strokes and myocardial infarctions, which again is a heart attack, in people that are infected with COVID-19. And this study from the United States shows a decrease in major adverse cardiac events, which is basically a grab bag term for lots of bad things that can happen to your heart. And when you're vaccinated, your risk of these major adverse cardiac events with your COVID infection is much lower than if you did not get vaccinated. So you can see Vivo was quite dishonest in his characterization of myocarditis in his follow-up video he posted after the space.
I was like, all right, do you want to do the math on what myocarditis in 1 in 10,000 people would total in a population of give or take 70 some odd million?
He ignored the fact that he was told the rate of myocarditis from COVID infection and the fact that he was told it was more severe with COVID infection. He ignored the fact that I told him that the risk of myocarditis is actually reduced when you're vaccinated and catch COVID. And he also ignored the other bad things the viruses can do to people, even young people.
All I'm going to add to that very thorough breakdown by Dr. Jonathan Laxton is this fact that a lot of anti-vaxxers like Viva Frei miss is that myocarditis is not the only outcome that you should worry about when it comes to COVID. COVID, the disease, can cause all sorts of things like multisystem inflammatory syndrome, lung damage, long COVID, and a whole host of acute issues that you may need to be hospitalized for. I'll use one example in the literature where the data are very robust to illustrate this for you. South Korea has done a fantastic job of monitoring the safety of COVID vaccines. They did a huge investigation into all of their vaccinated population as to how many cases of myocarditis, severe myocarditis, and death vaccines have caused in that country. So out of 42 million people who got vaccinated, there were only 8 people who died possibly as a result of the vaccine. We as scientists don't see these deaths and say, yeah, that's acceptable. We will try to make the vaccines even safer in the future and try to promote guidance that can reduce the risk of these things happening. But when we take it at face value and compare it to the damage that COVID itself can cause, then the issue of risk-benefit becomes really clear. Because among those 8 deaths, for example, none of them were under the age of 18. Meanwhile, there was also a very robust investigation into the deaths that COVID itself caused in people aged 18 and under in South Korea. And it turned out there were 46 people under the age of 18 who died from COVID in South Korea, and only 4 of them were fully vaccinated. Again, that's just death. That's not considering the other outcomes like hospitalization, multisystem inflammatory syndrome, etc. But even at the worst metric possible, death, COVID is much more deadly than the vaccine. Most of those 18 and under deaths were preventable, and they are worth preventing. But yet still, people like Viva Frei will insist that COVID poses 0 risk to children, and that is just not true. It's a total lie.
Another highlight was when the scientist cat, I forget what her name is, Luna Sanguina, went on to explain how it wasn't a contradiction when the UK government said the jab was safe for breastfeeding or pregnant women, because they needed to test on the general population in order to get that data to come to that conclusion?
So Viva also wanted to say that vaccines are recommended for pregnant people, even though they weren't tested in a trial and they didn't have any evidence for that recommendation, which is not true at all. So NACI, which is the body of experts in Canada that give vaccine recommendations to the Public Health Agency of Canada, clearly stated in January of 2021 that they should not be given to people that were not represented in the original clinical trials, including pregnant people. However, if a pregnant person really wanted to get vaccinated, they could have a discussion with their healthcare provider about the fact that there was no evidence in their specific population and make an informed decision as whether they wanted to go forward and get vaccinated. For example, we had a physician in our group that was pregnant at the time who decided to get vaccinated. So by April of 2021, data had accumulated from women that had become pregnant and hadn't realized it before they got the vaccine and were followed to make sure that it was safe, as well as the safety reporting databases such as VAERS, VSafe, Canada, Yellow Card Scheme, and all the others around the world that showed that the vaccines were likely quite safe in pregnancy. At this stage, the NACI recommendation was upgraded to a conditional recommendation that women could be vaccinated as long as they considered the risks and the benefits. And then in May of 2021, NACI upgraded to a full recommendation that pregnant people receive vaccine for COVID-19 based on ongoing safety review and evidence of no reproductive toxicity. There was also evidence that the antibodies, but not the vaccine, crossed the placenta, as well as COVID-19 was likely a risk factor for poor pregnancy outcomes. They still recommend discussing the risks and benefits of vaccinations with the patient. Then in the summer and fall of 2021, the safety data started to get published in the literature in 16 different studies. There was no signs of increased adverse events in either the mother or the infant, no increase in miscarriages, no increase in stillbirths, no impact on fertility, and no severe adverse reactions in babies that were breastfeeding. So you can see the public health agencies took this very seriously, reviewed multiple forms of data before recommending the COVID vaccines to pregnant people. If you want further data on this, there's a Dr. Vicky Mail, who is an expert in immunology and pregnancy, who has compiled all of this evidence together into a Google Drive document, and it will be linked below in the video description.
I said to that scientist, Luna Sanguine, whatever her name is, not only did she just describe real-time experimentation, but if you go to the UK government's website, as of today, updated as of December 2023, they still issue the warning that the jab is not to be recommended for pregnant or breastfeeding women due to an absence of data. So the UK government apparently is saying both A and not A at the same time, and this doesn't seem to raise any red flags in the minds of the so-called experts.
This is my favorite thing about this. It kind of shows why he's not a lawyer anymore and why he's just a rage-baiting YouTuber who grifts for attention and money. He can't even read a document. This page that he is showing from the UK government, which he claims says that the UK government is not vaccinating people during pregnancy because of safety concerns or lack of data, it's from 2021. It's from right after the clinical trials were done. And in the clinical trials, that was true. There was no data on how COVID vaccines affected women during pregnancy. In typical Viva Frei only reading headlines fashion, he looks at the top of the page and sees when anything on the article was last updated. And he thinks that that means that all of the information in that article is up to date to that date. However, if you actually read the page, it'll say that all of the text that is referring to the COVID vaccine clinical trials has not been changed since 2021. And if you look at actual guidance from the UK government, it clearly says that pregnant women should get vaccinated in their third trimester to protect themselves against COVID and to protect their child in the first 6 months of their life against COVID. This is clearly stated in black and white on this page, but yet he doubles down on this after the space on Twitter comments and then triples down on it. It's ridiculous. He cannot read a page to save his life. And yet he wants his 500,000 plus followers to trust his opinion when he is saying this complete nonsense that is literally going to get people killed. Because it is no question that vaccination during pregnancy is very safe and it offers huge benefits to an immunocompromised mother and a child once it's born. That's because those antibodies that the vaccine induces in the mother can be passed down to the baby, and they will persist in the first few months of their life, protecting them from illness during those first few months. All of these data are explained and compiled by the first guest I ever had on this channel, Dr. Vicky Mail. I'm including the link to her Google Doc where she has organized and explained all of this data in detail in the description below. So if you want to be smarter than Viva Frei, just go to one of those links and read 2 sentences into the paper past the headline. But seriously, do check out those sources if you're interested. There's a lot of information there.
The media lied or got it wrong. They weren't distinguishing between hospitalized with versus hospitalized from COVID.
We always distinguish that. Your last claim was that we didn't do that for hospitalizations, and then you folded that into deaths.
You're damn right I did.
Yeah, so that's wrong.
Oh, okay.
So we fill out the death certificates. I can post the document guidance by the FDA that says that you only mark COVID-19 down on the death certificate if it is the underlying cause of death.
Really? Are you familiar with the case of the 14-year-old in Alberta who died? They attributed to COVID?
And they were reclassified as not a COVID death when the mistake was found. All you do is you find the exception to the rule, and then you pretended that that is what happened everywhere.
And all that you do is ignore the egregious rule break.
So again, you're doing the same thing. You're gish galloping away from the point. So this has been a classic talking point from the vaccine movement throughout the pandemic and for other viruses as well. You try to minimize the impact of the virus by denying COVID deaths, saying they died only with COVID, so you can maximize the fear about the side effects from the vaccine. So as I mentioned, I worked at a large hospital with lots of hospitalized COVID patients and unfortunately had to fill out more death certificates than I ever care to fill out again. It was quite a devastating time. So I personally find this talking point quite offensive to the families and friends of the loved ones that died from COVID-19, as well as to the healthcare workers that witnessed all this death and some that even gave their lives early in the pandemic to help care for patients. If anything, COVID deaths were likely undercounted, especially early in the pandemic and in countries that didn't have the resources for widespread testing and diagnosis of their citizens. In the United States and Canada, you can probably remember that PCR tests were very difficult to get in the initial months of the pandemic. This study here, which looked at the first year of the pandemic, found that about 184,000 extra COVID deaths occurred in the United States that never made it into the official death counts. So one of his main arguments to say that deaths were not distinguished between with and from COVID was that hospitalizations were not recorded as with or from COVID. However, this doesn't really apply. Your admission diagnosis can change quite significantly as we get to know you better, see how your symptoms progress, perform tests and imaging. That would become refined. However, when we fill out the death certificate, we have a lot of that information in which we can determine the cause of death, plus possibly an autopsy or postmortem testing for the virus, and then put down the final diagnosis. And there were many guidelines for physicians, like this CDC document that was released in April of 2020, which clearly states that if COVID is thought to have played a role in the death, meaning if you hadn't had COVID, you wouldn't have died, then COVID should be placed on the death certificate. Viva then went on to apply that deaths could be labeled as COVID if the person just had an influenza-like illness, had not received testing. He was correct to point out that influenza-like illness, which is the symptoms you get with flu, aren't enough to distinguish between COVID and flu. However, you can see in this document from the CDC, it recommends that testing should be performed whenever possible, and that includes post-mortem testing, where you swab the nose because there'll be genetic material left over, and run the PCR to see if COVID-19 was present. It then went on to the next favorite activity, was to take anecdotes of mislabeled death and pretend that those were the rule, or at least made up a significant number of the death counts. One of the favorites is the motorcycle accident in Florida, which had mistakenly been labeled as a COVID-19 death. Ron DeSantis brought it up, and the Florida Department of Health removed it from the COVID-19 death counts. Another one is a teenager in Alberta who died of a tumor in the brain who happened to be COVID positive that mistakenly was labeled as a COVID death, and that one was also rectified. These stories are often accompanied by the accusation that these misclassifications often occurred to get increased money for labeling somebody as a COVID death. There's several problems with this. Number one, we don't get paid for a patient dying. End of story. Number two, this was specific to the United States and the CARES Act, in which they transferred increased payments of Medicare patients to help cover the increased costs of caring for COVID-19 patients, as well as the loss of income from elective outpatient procedures. This does not apply to the rest of the world. Canada does not fund healthcare in this way. We fund the bed regardless of what patient's in it and what their diagnosis is. So because of these concerns, the CDC actually took all 370,000+ death certificates from 2020 and audited them to make sure that they were all consistent with a COVID-19 death. And of the 370,000, 97% had a causal chain of events, meaning they had COVID, flu-like illness, pneumonia, ARDS, and then death that was consistent with a COVID-19 death. So there was no systematic or significantly large misclassification of deaths in 2020. Then Ontario, one of the most populous provinces in Canada, spontaneously decided to look at their death certificates after the last Omicron wave, and they found that less than 5% of deaths in each wave could be reclassified as incidental COVID and not dying actually from COVID. It increased during Omicron, but only to 8% of all deaths. Again, that does not support systemic misclassification of COVID-19 deaths. And I can tell you as a physician that actually fills out death certificates, I've had patients that incidentally swab positive for COVID, clearly died of something else like a bleed in the brain, and I did not put COVID-19 down on the death certificates, and nor did any of my colleagues.
So now I want to highlight some of his blatant hypocrisy. As I explained earlier in the video, his whole thing is that he does not trust science because some public health talking heads on the news got things wrong. But when I asked him, well, which experts do you trust? Because clearly he doesn't know anything. He's a lawyer who has no knowledge in science or data or anything. Who does he trust? He had this answer to say.
Here, one offhand, I would say Dr. Malone.
No, I'm not asking that. I'm asking how you parse information. How do you determine?
I listen to people. I listen to people thoroughly and thoughtfully, and hear their explanations, and then assess whether or not I think they're credible and whether or not
you just listen to people. Do you check sources? Do you read data? Like what?
Oh, I in as much as I can. Here's where, and by the way,
okay. So you make several claims here that are not supported by data.
Give me one.
Well, you said that we don't vaccinate into a pandemic. That is...
No, I didn't say that. I actually, if you had listened, I didn't say that. I said there was an expert who said who warned about the not vaccinating into a pandemic.
Oh, well, so do you not trust him then? Do you think that is...
I understood both arguments and the reasons for the theory being posited.
So which one did you go with? Which one have you promoted?
I think from the historical examples and the way things have gone, I think it's more logical that you don't vaccinate into a pandemic.
Okay, great. So which historical example teaches us that you should not vaccinate into a pandemic?
I think the absence of that would be
so smallpox, H1N1, yellow fever.
Well, I don't know. You could take I could go back. I could go back to the '76 swine flu, which might be one of them, which might illustrate some of the points. But
the '76 swine flu
and I know
was a dud.
Look,
nothing really happened with it.
Well, nothing really happened except they pulled the vaccine after 32 hospitalizations, but now we're up to 37,000 reported deaths.
No, they actually pulled the vaccine for the swine flu in that year because the pandemic was not turning out to be as bad as expected, and it was determined that the vaccine wasn't needed.
Well, here's we're going to agree to disagree. I'll say this: you guys can carry on with your discussion now. I think I've
run away, bye bye. You don't have to national party, just run away, bye bye.
So as you can see, he trusts people like Robert Malone or Dr. Drew or Dr. Peter McCullough. But Peter McCullough very infamously said on the Joe Rogan show this:
recovered, and then about 7-8 months later, he got sick again, tested positive again, and had a much milder case of it, but still got COVID twice.
Yeah, it wasn't a second case. This is what's happened.
For sure?
Yeah.
Yep, he said that you can only ever get COVID once. He said that very confidently and refuted Joe when Joe tried to say, but I know people who have gotten it twice. And he was very, very wrong. So by Viva Fry's own logic, he should not trust Dr. McCullough. Yet he does. He always retweets his stuff and repeats the things that he says. Because he's biased. He is working completely off of bias. He is working on zero critical thinking at all. He is just repeating the things that people say that he agrees with, without any regard for whether or not they're actually true. And there was even this moment where he said that he would trust a medical professional who is a practicing clinician.
I have spoken with very intelligent doctors who practice, Dr. Drew being one of them.
But Dr. Laxton was on the space talking to him, and he was just totally discounting everything Dr. Laxton said. 100% hypocrisy. By the way, Dr. Drew is not really a clinician who treats COVID patients. He treats mostly outpatients, from what I understand. That means he doesn't treat people in a hospital. He has people come to him and he gives checkups or gives advice and writes prescriptions. And there's nothing wrong with that. Well, there are problems with the way that Dr. Drew does it, Mainly, he works for a vitamins company that sells ineffective vitamins that he runs ads for on his show because he's a total sellout.
He doesn't care about that. He's too busy being perched on the lap of Dr. Drew to care about anything what anybody else has to say.
But it's just very interesting that he would trust someone like Dr. Drew and not Dr. Laxton, who has treated probably over 1,000 COVID patients who were in critical care.
Despite the safety and efficacy of the jab and the boosters, another one of them in the crowd, I think it's Debunk the Funk or something, simply refused to answer the question. And the ultimate kicker in all of this, one of the other doctors who was in on the space tweeted out later on that he got myocarditis from his first Moderna shot.
So after about 2 hours of this space and him providing zero evidence to back up any of his claims, he then went on to a classic anti-vaccine talking point and asked everybody in the room how many boosters they had. So he had two major reasons for doing this. The first, which he did in this video, was to clip sound bites of vaccine advocates and present them as hypocrites pretending that they were not up to date on the vaccine recommendations and therefore you couldn't trust what they said about the vaccines. This was false and very dishonest. So I've had 4 doses so far of mRNA vaccine, and then I caught COVID for the first time in the fall of 2023, and it'll be 6 months after that before I get my next dose. Not the gotcha they think it is, because I work with some of the most vulnerable people in society, lots of comorbidities, elderly, immunocompromised, and I will do everything in my power to protect those patients. They are trusting me with their health, and I will risk a sore arm for a couple days as well as a swollen lymph node to ensure that I do not spread a deadly infection to them.
The correct question to ask back to anybody who says, how many boosters do you have, is how many do you think are needed? I have been very clear on my channel about this before that 2 to 3 doses of COVID vaccine, especially the updated ones, are more than enough for most people. That's because the point of COVID vaccines, like I said, is not to protect against infection. And that's what continuous boosting is mainly going to do for you. Sure, it will probably expand your immune memory, and we can have a reasonable debate about who should get more boosters. But the primary goal of getting more boosters is to prevent against infection during periods of high prevalence of COVID cases in your community. That's why the CDC will recommend boosters for elderly people or immunocompromised or otherwise vulnerable people during winter surges of COVID. But not everybody needs continual boosters. In fact, the current CDC recommendation reflects this data and says that even those who are unvaccinated currently only need 1 dose to be up to date. I had a primary series of 2 doses in 2021. I had a 3rd dose in 2022 when Omicron came around. And I recently just had a 4th just before my son was born so that I could protect our household and mainly him from COVID. So just to reiterate, this whole question of how many boosters do you have is again a symptom of Viva Frey's lack of actual critical thinking. Because when he reads headlines and watches the news, then he just sees that a new booster is recommended. He understands nothing about who it is recommended for or the reasons behind why a new kind of vaccine is being issued. If he actually read and understood the data or listened to the Advisory Committee on Immunization Practices meetings where they actually discuss the logic behind these recommendations, he would understand that, well, not everybody needs 8 or whatever boosters he thinks they need.
Anyhow, it was as infuriating as it was revelatory, I think. I don't care if I won or lost.
I find it interesting he's saying he doesn't really care who won the exchange because he cared so much right after the space that he put out a survey to his 500,000 followers in which he asked whether himself or the experts, in quotation marks, had won the exchange. Guess what? He lost by quite a large margin, as you can see, which is probably why he's saying now that he doesn't care. And yet he went on to make this video, which we are currently responding to.
Not that polls mean anything, but man, that's gotta hurt losing a poll on your own page when you have like 10 times as many followers as anybody else who was in that space with you.
.com if you want to buy some merch.
Oh, that reminds me, while he's advertising his merch, I might as well say you can buy mine and Dr. Laxton's merch at www.wedon'thavemerch.com. Do not look that up. That's not a real website.
Merchandise. You can't have these. They belong to me.
So at the end of the day, there's absolutely no question that COVID vaccines have far more benefit than they have risk. They drastically reduce the suffering and death caused by COVID. And no one deserves to suffer. No one deserves to get stuck with thousands of dollars of hospital bills after a stay due to COVID-19. And no one deserves to die prematurely. But people like Viva Frey who just want to rage bait and lie to make money because that's literally his job. Seriously, he's not a lawyer anymore, so he can't make an honest living any other way. People like him are actively choosing the path of more harm and encouraging their viewers to do the same. It's disgusting, it's shameful, and I hope that this very thorough explanation by both Dr. Laxton and I taught you something, because that's really all we have to offer you is the science, the data, and knowledge. Well, I think that's going to do it for this week's video. That was certainly a fun one, and I definitely appreciate Dr. Laxton chiming in and helping out with some of the clinical aspects of this video. If you want to check out Dr. Laxton, he is on Twitter, and he's also making content on TikTok. I'll link those in the description. And Twitter is a garbage-sinking hellscape of misinformation, but if you ever want to come by some of the spaces that are run by a user called The Real Truther, which is where this discussion with Viva Frey happened, feel free to join. They happen every week. I'll link his account in the description as well. Anyway, thank you so much for watching. I really do appreciate it. And as always, all of the links to all of the data that we have talked about in this video are in the description below so that you can read them for yourself. If you enjoy this video, then go ahead and subscribe so you can catch me next week where I'll be debunking some more funky stuff. See you then.